There's so much more evidence now. I mean,
Yeah.
when hormone therapy was really taboo 20 years ago, and now menopause is a buzzword. Estrogen is a growth hormone. And so you think about things growing, hair, skin, nails. Estrogen is good for bones.
Mm.
There seems to be some protection on the heart. The thing that always fascinated me before I really was trained on things was like, how are some women going through menopause and they're fine and
Mhm.
some women not? It just always fascinated me. Now, you'd have on one hand one woman who was naturally going through menopause
Mhm.
and she was having debilitating hot flashes. She still had her ovaries. And this lady over here had her ovaries removed and felt fine. That made no sense to me. You had your
Right.
ovaries removed. You don't have anything going on. This lady here. So that all has to do with your estrogen metabolism. Published breast cancer survivors got systemic hormone therapy as
Mhm.
well as vaginal hormone therapy,
Mhm.
and there were no increased risk
Mm.
of breast cancer with that.
Hi, everyone. I'm extremely excited to be joined by Dr. Tara Scott today, and we're going to be talking about estrogen and breast cancer. Dr. Tara Scott, or Hormone Guru, helps people find the cause of their symptoms and get them on a path to optimal health. With over 25 years of experience and 3 board certifications in OBGYN, functional medicine, and integrative medicine, Dr. Scott has helped thousands of patients struggling with hormone issues, including endometriosis, breast cancer, weight gain, and more. She is the founder of Revitalize Medical Group and Hormone Guru Academy, a course to help patients improve their hormone symptoms themselves. After suffering from infertility and endometriosis, she now helps others achieve that same balance. She recently partnered her practice with Forum Health to take Revitalize to the next level. Dr. Scott has been speaking, including a recent TEDx talk, and educating for over 10 years and has taught doctors her approach in 5 different continents. For her expertise, she has been featured on The List TV, Women's Health, Shape, The List, Newsweek, Parents, Authority Magazine, and on numerous podcasts. So, Tara, thank you so much for taking the time to have this discussion, and welcome to the podcast.
Well, thank you for having me.
I wanted to start off by asking you just about a little bit about your personal journey, because a lot of people in the realm of OBGYN, GYN, they will tend to take the more traditional route. And so it's very interesting when I find conventionally trained doctors, especially GYNs, taking more of a going against the grain when it comes to a lot of what is conventionally taught. So I'd love to hear a bit about that as far as your journey goes.
I mean, you're right about that. I was a traditionally trained OBGYN, and when I finished residency, I was able to do an emergency C-section and get the baby out in under a minute. But
Mhm.
if you came to me with any hormone issues, we got zero
Right.
training. We had infertility training and getting pregnant
Mhm.
and checking hormones in the guise of assisted reproduction, but really no training. So a lot of that training, if you're interested, you either had a personal issue or patient or a family member, and you really have to seek it out, because the misnomer is that as an OBGYN, we would be the experts on
Mhm.
hormones. So
Right.
I became interested first, as you mentioned, with my own infertility journey, just having to take all the medications to be able to get pregnant, and then was diagnosed with Hashimoto's thyroiditis and endometriosis. So after that, it was right around the time that the WHI came out, where everybody was panicking about hormones. And I started going to a couple holistic, it was really just first hormones without a lot of science behind it, but about compounding hormones and hormone options. And then really, the more you learn, you find out the less you know, right? So, I mean, there wasn't a lot of education. This is 2003. And so just started taking a lot of courses and learning on the job. And then, the more formal A4M fellowship came up. I did that and finished that in 2012. I've done most of my IFM modules and then got the board certification with integrative medicine as well. So, it's great that now with social media and with all these online platforms, there are more options and opportunity to learn. But as a traditionally trained OBGYN, you really have to, the amount of time and money it takes to get that I've used to get to this point is a lot.
Yeah.
So you really have to be passionate about the mission, because it's not the easier way to go. I think now there's a lot more resources out there with integrative training, functional medicine training courses, which is great.
That's awesome. It's so unfortunate that as physicians, after spending hundreds of thousands of dollars in medical school, we don't get this in medical school. And most of us have to take this journey of time, money, and all of this after, a lot of times, even after residency. You get that
Hmm.
wake up call when you go out there in the real world. So it takes a lot of bravery and courage because it is going against the grain. And so I'm definitely in the same boat as you, although maybe a little bit behind in that journey. So
Well,
um,
there's so much more evidence now. I mean,
yeah.
when hormone therapy was really taboo 20 years ago, and now menopause is a buzzword, and
Mhm.
it's really, I really actually feel more called to help the perimenopause people because now
Mhm.
menopause is a little bit more acceptable, but it's the
That's right.
perimenopause cohort that is getting maybe invalidated and
Yeah.
neglected by our traditional healthcare approach.
Yeah. And we just have to step into that role. I see patients all the time that they go to their physician with all these complaints and they just get that you're fine or you're not old enough or something like
Yeah.
that. And it's very, very frustrating. But I wanted to dive into estrogen as deeply as we're able to with the time that we have. But maybe just as a baseline for the people that may be very new to this, just an overview of the menstrual cycle. And then maybe we can get into a little bit of estrogen metabolism because that's an area that often gets, again, not well taught or even discussed in more of the conventional circles. So I definitely would love if you could expound on that a bit.
Right. So the whole menstrual cycle is really aimed at reproduction, but
Mm.
that's not to say that those processes have to be balanced for you to feel good. Besides from actually getting pregnant, there are other functions of your hormones in the body.
Right.
So, the beginning of the cycle, we arbitrarily say starts with day one, which is full flow of your menstrual cycle. At that time, your brain is sending a signal to your ovary for an egg to get ready and develop. As
Mm.
the egg grows, it produces estradiol. In the middle of the cycle, there's a trigger from the brain hormones again, FSH and LH, mostly LH, to release the egg or ovulate. There's a
Mm.
little drop in estrogen at the middle of the cycle, and at that point, the shell of the egg is kind of like the simplified way of explaining it,
Mm.
invaginates and forms the corpus luteum, which then produces progesterone. So progesterone is progestation. So
Mm.
its
Yeah.
job is to prepare the body for conception and pregnancy. So at that time, the progesterone level peaks about a week after ovulation,
Mm.
and conception actually occurs in the fallopian tube. So either the egg and sperm meet. If they don't, by a week later,
Mm.
the hormones there's a it's a simplified way, there's a check mechanism that so that you don't release another egg while you're figuring out if
Mm.
this one's going to conceive, and then the hormones fall and the whole thing goes over again. The problem is that, again, once you get into your 40s, you're not necessarily looking to reproduce, but these eggs are old. So if you
Mm.
would be pregnant and you would have come to me as an OB, I would have labeled you advanced maternal age over 35.
Mm.
That does mean that the egg quality is not as good, and you, if you get pregnant, could have an increased risk of chromosomal problems if you are pregnant. Well, even if you're not interested in fertility, if the eggs aren't good enough to reproduce, it would translate that the hormone production is altered. So what ends up happening is they are, I say, hard of hearing. So the stimulus of FSH doesn't necessarily get an egg to develop. So then guess what? The FSH has to increase. And then you end up getting more eggs responding because there's more FSH. Just think about somebody yelling. More people are going to turn around and say, what's going on? So
Right.
these eggs are growing, but only one can ovulate. So you end up getting actually more estradiol.
Mm.
And then with ovulation and the poor quality follicles, you actually get less progesterone because they're old. So you end up getting what's called estrogen dominance. And that's where the craziness starts with the
Mm.
heavy periods and possibly with hot flashes and the weight gain and the anxiety and the moods and the sleep disorders from the balance between estrogen and progesterone being off.
Okay. Yeah, that's a really good explanation. And um, what is the best way to understand estrogen metabolism, or if we could get into that a little bit about what eventually happens to estrogen, or maybe we could talk a little bit about what the main effects of estrogen, main purposes of estrogen in the body are, and then go towards the journey it takes from its production to the metabolism.
So estrogen is a growth hormone. And so you think about things growing, hair, skin, nails, estrogen is good for bones.
Mm.
There seems to be some protection on the heart because you don't hear of women having heart attacks in their 30s and 40s.
Right.
You do of men. And while tragic, it's not surprising if you hear about a male having a heart attack in
Mm.
his 40s. It's just very unusual for a woman,
Mm.
with no other risk factors to have
Yeah.
a heart attack. So there's some protection against heart disease, which is the number one killer in women. We know that there are changes in estrogen that result in mood issues, postpartum depression, midlife, puberty. Those are times where you're susceptible to anxiety or depression.
Mm.
So estrogen supports serotonin and is connected with your neurotransmitters and your mood. And there's other things like energy, your sugar metabolism, your basal metabolic rate. It's been proven that goes down when you go through menopause. So there's a lot of other functions in the body of estrogen. We're seeing a lot of studies now later of women in menopause later, like in their 60s, showing that estrogen is brain protective. Observational studies showing a 60% reduction in Alzheimer's, which is
Yeah.
huge. Progesterone, on the other hand, is kind of like balancing estrogen. It's more like a diuretic. It's an antidepressant. It has actions of GABA, which is an inhibitory neurotransmitter in your body. And so it's involved in keeping estrogen in balance, keeping your salt and water retention through its precursor to aldosterone, and involved in sleep and also moods. So those two things, those are the main things. Now, testosterone, we don't hear a lot about in women, but obviously we also have testosterone. Most of our testosterone is coming from adrenal sources via DHEA, dihydroepiandrosterone. DHEA is made largely in your adrenal glands. So testosterone has functions in your body, not just for sex drive, but also hair, skin, nails, mood, structural integrity of your muscles, muscle joint aches, skin being dry, vaginal dryness, muscle mass and stamina. So there's a lot of other things that testosterone is responsible for, as well as your adrenal hormones, which is a whole nother conversation.
Right.
So the thing that always fascinated me before I really was trained on things was like, how are some women going through menopause and they're fine and some women not? It just always fascinated me. Now you'd have on one hand, one woman who was naturally going through menopause and she was having debilitating hot flashes. She still had her ovaries. And this lady over here had her ovaries removed and felt fine. That made no sense to me. You had your ovaries removed. You don't have anything going on. This lady here. So that all has to do with your estrogen metabolism. And this is a huge way that we totally miss the boat with hormone replacement therapy. So I explain it to my patient like this. Suppose I tell all my patients to drink 2 liters of water. And you say, okay, I'm going to follow it. I'm going to drink 2 liters of water a day. Well, what if you are going to run a marathon in 80 degrees weather and you stick to the 2 liters of water and you don't deviate? Well, my recommendation now makes you dehydrated. Or what if you stick to my recommendation and you're a dialysis patient and I've overloaded you and you have heart failure based on the water? Now, is water the problem? Or is it the clinical situation of the patient and how they are metabolizing it? So the same goes for estrogen. How can estrogen be so bad? I mean, I know we have some synthetic versions out there. We have xenoestrogens, we have endocrine disruptors, but how can estrogen be so different for people? And so basically that's where estrogen metabolism comes in. And we learn about this in physiology. We learn about cytochrome P450, and then we don't even know how to apply it to modern day, except for pharmacogenomics, right? Certain things are metabolized by certain enzymes. So we know that, again, I explain to my patients like, okay, all hormones are different. There's 3 forms of estrogen. There's estradiol that comes from the developing follicle. There's estrone that is made by peripheral conversion via DHEA and even testosterone. So you don't even need ovaries to make estrone. And then you have estriol, which is a weak end metabolite, meaning it can't turn into a different type of estrogen, while estradiol and estrone can go back and forth. So they all are different in how they make the uterus grow and the breast grow. So that's one of our concerns about estrogen being a growth hormone. What's the correlation, as you mentioned, with breast cancer? So the problem with estrogen is it goes through a 2-step process, really even 3, depending on who you talk to. 2 in the liver. So estrogen's floating around, the ovaries made it, and there's a chemical process initially that deactivates it and makes it what's called an intermediate metabolite. And that
Yeah.
is basically cytochrome P450, three enzymes to be protected. So think of it as a highway. It's going down, it's changing it. And the second phase of estrogen detoxification, also in the liver, is methylation. So it inactivates it, puts it in a box, ties a bow, sends it down the slide to be pooped out, right? So that's how you get rid of estrogen, and then you poop it out. And there's that whole issue with the bacteria in the gut. Do you have enough? The bacteria can make something called beta-glucuronidase, which can send the estrogen back into your system. So there's lots of actually studies documented. I've seen some of my traditional colleagues really like kind of make fun of the fact that we say about how estrogen's detoxified and the bowel is, important that you
Right.
can send it back into circulation. And so I got on PubMed. I'm like, can I support this? There's so many articles about the estrobolome and beta glucuronidase and all this. I mean, so there's a lot of data and it's basic science, but we're just
Yeah.
not taught to it. That sounds so weird that what we poop out would have to do with our estrogen detoxification. So if you think about it, everybody does this at a different rate.
Mhm.
Just like everybody spends on a different rate. Some people charge on their credit card and they pay it off completely.
Right.
Some people charge and they pay the minimum payment. And then over time, that finance fee isn't an issue, but over time, if you keep doing that, you're going to get a huge backup and debt.
Yeah.
So that's what women who don't, and men too, that don't have efficient estrogen detoxification. It's those enzymes we talked about. Are they coded genetically that they're slow, or there could be other things that are affecting us, like insulin can affect it. If you have a lot of insulin, endocrine disruptors, your diet. So it's kind of crazy. And again, as you know, because you've dedicated to training and to learning all this, it's overwhelming. We're not taught anything
No.
applicable about cytochrome P450 and physiology, right? We're just taught about maybe genomics, or not even pharmacogenomics, drug metabolism, right? Possibly. So, it's fascinating to me. And it was like eye opener and game changing when I started looking at people's estrogen detoxification.
Yeah.
So I was like, that's why it makes sense that someone with no ovaries could still have high estrogen levels years later, which is kind of interesting.
Yeah. Yeah. It's so important that you mentioned that. I feel like patients look at us and they think that we just have all the answers, right? And assuming that we know everything and we were trained properly. Whereas, just like you mentioned, when I came out of residency, I felt that I could take care of a very sick patient in the hospital. But as far as it came to hormones, I was probably a beginning med student as far as that was concerned. So that's the journey where you have to really reconcile with yourself and go like, there are aspects of this that I know nothing about, and then start that journey. So I wanted to ask you about mechanism of breast cancer development, as just to understand that better. So, how would we explain to someone? Because again, there's these true tracks where again, estrogen drives breast cancer has been the dominant theory since the Women's Health Initiative came out in 2002 July, and we obviously have all this data that does not, or that tells us the opposite. So I want to understand exactly how the best way to explain out there to the general public about if someone wants to understand how estrogen behaves with breast cancer, or how it interacts, and what really happens in that breast cell for one person to develop breast cancer and the other to not.
Well, yeah, it's a very complicated
Mhm.
situation, but if you think about it, breast cancer, what is actually cancer?
Mhm.
Cancer is something turns on the cell. Like,
Yeah.
go back again to our physiology. There's supposed to be the cell cycle.
Mhm.
If the cell gets out of line and it starts rapidly dividing, that cell is supposed to commit suicide, right?
Yeah.
Something is supposed to take care of it so it
Mhm.
doesn't happen. It's the same thing as eczema. It's an overgrowth of skin cells, right? So
Mhm.
breast cancer is a rapidly dividing
Mhm.
breast cell of origin that obviously then takes over. And a lot of times with cancer, people actually Sometimes they die of the cancer if it's in a vital organ, or they just die of malnutrition because that cancer cell siphons off all that nutrition and keeps growing. So it could be like bulk syndromes. So the cell of the breast is glandular. The breast is a gland used for mammary glands. So we have similar cells. And if you look at our textbooks, Reproductive Gynecology by Dr. Leon Spiroff, he says the uterus is like the breast. So early in hormone therapy, we gave estrogen alone because they couldn't figure out how to make progesterone. So they made a synthetic version for oral contraceptives. But when it came to hormone therapy, they couldn't figure out how to make progesterone because it's very difficult to make. So they gave a synthetic version called Provera, or medroxyprogesterone acetate. We call it MPA. And so what they've since found, since the WHI, is that certain things cause the breast cell to grow, certain things cause the breast grow to counteract that, right? So it's kind of like good cop, bad cop, or accelerate and break. So the first thing that happens with breast cancer is that tumor gets analyzed for hormone receptors, okay? An estrogen receptor, a progesterone receptor, and a HER2 neu. So we know there are estrogen and progesterone receptors in every cell of the body. There's actually an alpha and a beta estrogen receptor, and the progesterone receptor is a very more complicated, it's a supernucleus complex that has different like mineral, corticoid. Anyway, it's very complicated. It's not just 1 and 2. So estrogens 1 and 2. So alpha seems to cause growth and beta seems to inhibit that. So beta is the brakes, alpha is accelerate. So the first thing is how do the hormones interact with the receptors? So estradiol being the strongest hormone causes growth. Estrone, which is the hormone made in the muscle fat, seems to preferentially stimulate growth at the alpha receptor more than the beta. And then estriol is weaker and seems to stimulate more the beta. So the problem is like that credit card, if you charge more than you pay off, with that progestin, so you'd have growth with the estrogen, but with that progestin, you had actually anti-apoptosis, apoptosis being cell death. So you'd have growth and more growth. So a lot of the original hormone preparations are stimulatory to the breast, specifically MPA or Provera and Premarin. Premarin is a different type of estrogen made from horse urine. It's a form of estrone. It's mostly equilin sulfate and estrone in that. So those are more going to make the breast grow. So when we analyze what causes breast cancer, only 1 in 8 people actually have a hereditary issue with breast cancer, right? So there are what we call now a large genetic cancer panel that, main labs are going that have BRCA1, BRCA2, RAD50, PALB2, CHEK2, all these what we call single nucleotide polymorphisms, but those are tumor suppressor genes, meaning you have an alteration in your body's tumor suppressor gene. So you don't suppress tumors. Now you can grow. So that's one mechanism of breast cancer. The second is, in my mind, is this estrogen detoxification problem, a SNP or a failure of estrogen detoxification. So you actually have more estrogen, not paying off your credit card, and you have a lot of endogenous estrogen. And some people think it's also endocrine disruptors, which are not necessarily phytoestrogens or things that are acting as estrogen, but phthalates, like things in hair dye. So chemicals that we're exposed to that are turning on the cell to make it grow. So there's a lot of environmental things that are thought to be linked to breast cancer. The genetic is either the failure of a tumor suppressor or the problem with estrogen detoxification. Or maybe you don't have a problem with estrogen detoxification, but you just make a lot of estrogen. So you've taken estrogen, you make a lot of estrogen. There's actually not a lot of studies looking at this, because I actually presented a poster not last year, but the year before, so 2022 at the North American Menopause Society meeting on breast cancer. And my issue is, I feel like, it's great that we're doing early detection, but we should really be doing prevention. So I did a comprehensive literature search on like how should we be checking hormone levels in people?
Mhm.
And should we be checking levels in breast cancer people, right?
Yeah.
Should we? So there's only been a couple studies. One of the studies was the Nurses' Health Study, where they did look at luteal levels, and they did find that women that had higher estrogen levels, estradiol,
Mhm.
in the luteal phase or after ovulation correlated with a higher risk of breast cancer. There are some studies that show higher testosterone premenopausal associated
Mhm.
with breast cancer. And then there's another study called the EPEC cohort, so estrogen, progesterone in cancer.
Mhm.
They've put out a lot of really great studies about hormone therapy. And they put out a large study in 2008 that showed observational. There's
Mhm.
80,000 people, so they had people taking estradiol through the skin, either a gel or patch, and micronized progesterone, which is bioidentical.
Yeah.
And in that cohort, women 40 to 64 had no increased risk of breast cancer, and it lasted 8 years. But the women that took the synthetic progestin had, I think it was a 33% increase, and the women that took estrogen only, which is another thing that we do in the United
Mhm.
States after hysterectomy, also had an increased risk of breast cancer. So it matters. So the position statement of the Menopause Society says that it's the dose of hormones, the
Mhm.
duration, the type of hormone. So there's a lot of variables when you're talking about, what causes breast cancer.
Mhm. Right. And people talk about so the good estrogens and the bad estrogens. And are you able to mention, because I know there's different metabolites, and so are you able to tell us, what are considered the quote unquote good ones and the not so good ones?
Well, that's what the estrogen metabolites are. So we went through
Mhm.
the three different types of
Yeah.
estrogen, and I don't really like to call estrone bad, but it's just
Mhm.
too much estrone does have the propensity to stimulate growth in the breast and the uterus. So I always am checking estrones in patient. And the thing about it is testosterone aromatizes to estrone with one
Mhm.
enzyme called aromatase. So men can be susceptible to this as well. So that's an important thing to look at.
Mhm.
Also, looking at the metabolites, when the first step of estrogen metabolite, those intermediate metabolites are thought to be more harmful
Mhm.
until they're detoxified. So think
Yeah.
about when someone goes through rehab
Mhm.
and they go through DT and they're detoxing, they feel worse before they feel better.
Right.
That's
Mhm.
like the process of changing it. It's a chemical reaction, could be hydroxylation.
Mhm.
And then the second step is methylation. So those intermediate metabolites, specifically for hydroxyestrone,
Mhm.
seems to be the one that has an increased risk. It has been increased in patients with breast cancer in their
Mhm.
urine, in cellular preparations of adenocarcinoma. They've seen more 4-hydroxyestrone. So that's what we kind of call the bad
Mhm.
estrogens.
Right.
There used to be 16-hydroxy, used to be thought of as possibly a bad estrogen. There used to be something called a 2:16 ratio. We don't really do that anymore.
Mhm.
16-hydroxy is a precursor to estriol,
Yeah.
which is not thought to be a harmful estrogen. And so
Mhm.
that theory has kind of fallen out of favor.
Mhm. Okay. I wanted to take a brief step back and just away from breast cancer a little bit. And we were talking initially about hormone replacement and how important that is. And we were talking before about not only menopause, but also, perimenopause and how we can help these women. And so aside from breast cancer, I just wanted to see if we could talk about how we can effectively use estradiol as hormone replacement therapy for women suffering from symptoms. So as we go or as women go into menopause, we're talking about declining estrogen levels and all of the symptoms that occur, the vasomotor symptoms, hot flashes, night sweats, vaginal dryness, the bone loss, the increase in cardiovascular risk, the cognitive risk increase, and the weight gain and everything that you have. So if you could just speak to perhaps the importance of estrogen replacement in the form of bioidentical hormone, and perhaps a bit of the details in terms of how you generally approach that in giving women.
Yeah. So again, estrogen still has a bad name. And I feel
Mhm.
like if you went out on the street right now and pulled 10 of your internal medicine colleagues,
Yeah,
10 of them would say not to take hormone therapy. If
right.
I pulled 10 of my gynecology colleagues, probably 9 would tell
That's
you
right.
not to take hormone therapy. And that's the
Mhm.
crazy thing. I don't know why the media hates hormone therapy.
Mhm.
So because of that study in 2003, now think about that. The study that was done in 2003, the WHI, was not done to look at risks. It was done because they wanted to get the FDA indication for primary prevention of cardiovascular disease. So what does that mean? The indications for taking hormone therapy, according to the FDA, are vasomotor symptoms, so hot flashes, night sweats, genitourinary symptoms of menopause, which is vaginal dryness, like you said. I don't know why those balloons are going. Vaginal dryness, painful sex, nocturia. The third thing is prevention of bone loss, which is applicable to everyone. The death rate 2 years after a hip fracture is higher than 10 years after breast cancer.
Yeah.
So osteoporosis is a big disease burden with women living longer. And the fourth is if you have premature menopause, which primary ovarian insufficiency is before 40, but premature menopause is thought to be before 45. So they wanted to add a fifth indication for primary prevention of heart disease. So they wanted everyone, think about it. Why is the study being done from a drug company? To get everyone to use their product, right? Because now if they get the FDA indication for prevention of heart disease, then you're getting all these women with no symptoms that can now take it for prevention, right? So they set out to do that study. They had the average age was 65. After 5 years of use, they saw that there was an increased risk of breast cancer and blood clots, and everyone panicked. So the problem is first of all, there were only 16,000 people in that study. 8,000 got the drug, 8,000 got the placebo. In the study that I told you earlier, E3 EPIC, it was observational, but there were 80,000 people in it. So a lot more people were in it. So what does it actually boil down? That those are the reasons to take hormone therapy according to the FDA. However, I have also seen people, their mood improves, their energy improves, their weight can get better, their cognition, their memory can get better, their sex drive can get better, even just with estrogen. We're not even talking about testosterone. Dry skin, itchy skin, hives, all kinds of weird things, dry eyes. So all those things can be not indications per se to take hormone therapy, but benefits of people taking it. So the Menopause Society looked at all the data and they said between the ages of 50 and 60 or within 10 years of your last period, there are more benefits for you taking hormone therapy than risks. And so they quote the breast cancer risk as 1 in 1,000 for estradiol and micronized progesterone, and 3 in 1,000 if you're going to take something like Prempro, which I don't recommend anybody use anymore, and as I'm sure you don't either. But I'm shocked that people are still out there using it. Shocked. So there are reasons to take estradiol, and if you think about it, estradiol. Think about also all other endocrine things, right? When we talk about giving back thyroid hormone, that's bioidentical. That's levothyroxine. It's a salt, but it is chemically identical to thyroxine, right? Liothyronine, thyrionine, right? When we talk about insulin, now you're probably too young, but when I was a resident, we used beef and pork insulin. That meant they got the insulin from a cow or a pig, gave it to the patients, and they had these little wheels sometimes if they had an allergy to beef or pork insulin. Somebody now found out in the lab how to make human recombinant DNA insulin, right? So that's what we use. We're not getting insulin from patients' veins, isolating it and giving it to patients. Someone's making it in a lab, right? Someone found out in a lab how to take a Mexican yam, and I don't know the compound. It's like Diogenin or something. I'm going to mispronounce it. So they manipulate it. So they manipulate it to be like estradiol and micronized progesterone. Now, we took something, I don't know, we used to take like 2,500 pig ovaries, pregnant pig ovaries, to make 1 milligram progesterone. We're giving 100 daily. So when they made the synthetic progestins for birth control, some were from a testosterone derivative, some were from a progesterone derivative, and those are called progestins. Those are not chemically the same as what our body makes. Just like you can put sugar in your coffee, you can put Splenda in your coffee, right? Splenda has 0 calories. If you have a diabetic patient that has a blood sugar of 30 on the floor, are you going to give them Splenda? No. Because you need to raise their blood sugar so they don't pass out, right? You're going to give them glucose tablets, right? So that is the hormone that the brain can use, not Splenda. Splenda sweetens your coffee. That's why birth control pills can prevent pregnancy. They can even help your bleeding. They can even do some non-contraceptive benefits, but they're
Yeah,
not replacing the hormones that you don't have.
absolutely. Is there a preferred method that you use in terms of patch versus cream, vaginal application versus topical? Just
Yeah,
curious.
so a lot of the data, especially the Ester cohort in 2008 and some other studies since then have shown that the risk of blood clot is actually with oral estrogen because when oral estrogen goes, first of all, you only absorb about 10% of what you take orally. So
Right.
think about every time you take a capsule, the levels are very erratic. So a lot of women, when they take oral estrogen, have breakthrough hot flashes in the early morning because they take the pill in the morning. So then it doesn't last as long.
Right.
When you take something oral, it goes to the liver. Estrogen augments hepatic synthesis of proteins, one of the proteins being the blood clotting proteins. So that's how that's thought to have an increased risk of blood clots. But when you use estrogen through the skin, it does not have that. It doesn't go through the liver. The other reasons I choose not to use oral estrogen, erratic levels, increased blood clotting. It also increases your triglycerides and your CRP. So it's not really that good for cardiovascular health. But anytime it raises hepatic synthesis, it increases protein. So if you think about it, you give oral estrogen, you're going to increase SHBG, thyroid binding globulin, cortisol binding globulin. If you increase the binding protein, you are decreasing what's free. So just by giving oral estrogen, you've now decreased a woman's free thyroid hormone and free testosterone. When women really probably have lower testosterone, have low libido around menopause, and have a alteration or slowdown of the metabolism, the last thing you want to do is make those hormones not available as well. So I don't give oral estrogen for those reasons. A lot of my patients are on patches because it comes in generic. It's generally covered by your insurance. There are like 4 or 5 different doses. If they have a latex allergy, I will use an estradiol gel. There's several different formulations. The difference between them are the doses and the half-life. So you've got to kind of be careful and be aware of that. I also do have some patients that for whatever reason don't do well with estradiol gel. So we use a compounded form called Bias, which includes estradiol and estriol. And so they seem to do better with that mix. Kind of think about it like how everybody's different with alcohol, right? Some people can have a glass of wine, 2 glasses of wine. Some people can have 5 beers. Some people can have shots. I mean, everybody has a different tolerance. So that's also with hormones. Everybody responds differently, and it may be based on their metabolism. It may be based on a lot of other factors.
Okay. And I'm curious if I could lastly ask you about estradiol use in breast cancer treatment, because I know that when we look at even in the WHI trial, the estrogen only arm, even though that was Premarin, and so that was synthetic estrogen, showed a decrease in the incidence of breast cancer, right? And so, am I right about that?
So that was conjugated equine
Yeah.
estrogen. There were 5,000 people that got the placebo, 5,000 people that got the drug, and they did not see an increase in breast cancer with conjugated equine estrogen. However, this is my pet peeve, is estrogen only with the uterus. In the Nurses' Health Study that had 122,000 people, so that was 5,000, 122,000 people, the longer you took estrogen only, the higher increased risk of breast cancer. And it was 20, 30, 40% increase. In the E3 EPIC cohort that had 80,000 people, again, observational, not placebo controlled, there was an increase in breast cancer with estrogen only. Relative risk was 1.3. So it really bothers me when they say there's no increase with estrogen only, because there's one randomized placebo-controlled trial with only 5,000 people for 5 years, where you have these other larger Nurses' Health Study is massive, right? So anyway, reframing that, the question is different about estrogen after breast cancer. So it's very controversial because unfortunately, no oncologist will ever sign off on it. So what do we know? We know that even just recently, there were more articles that looked at vaginal preparations in vaginal estradiol, vaginal DHA after breast cancer. There were no concerns. There was a study done in either Sweden or Switzerland now. I should know which S country. It was in 2022.
Right.
Just published breast cancer survivors got systemic hormone therapy as well as vaginal hormone therapy, and there were no increased risk of breast cancer with that. That study will not be done in the US because for whatever reason, everyone's been scared. So what do? If they're 5 years out of their breast cancer and I feel like they have a higher risk of osteoporosis, if I feel like they have a higher risk of, heart disease, we'll talk about it. I've given patients with breast cancer hormone replacement therapy, but we're monitoring them, we're properly consenting them. And I tell them, I have no study. This has not been done. We don't have any evidence behind it, but I can tell you what the science says, and I can tell you what we're going to do. And because if you think about it, some of these patients have no breasts. They've had bilateral mastectomies. So are we worried about a recurrence from the off chance that there's one little cell circulating? And then you're gonna have this markedly increased risk of heart disease with these patients. Their quality of life is going down. They're symptomatic, and these women are deprived of hormone therapy. I don't think the same is true for males that have their testicles removed. I'm sure that it's a little bit different. I'm sure they give them hormone therapy, but it's a little bit of a dichotomy.
I think it's interesting. Some of Dr. Avram Blooming's work is interesting, I think, where he's using conjugated equine estrogen to treat breast cancer, even at I believe at higher doses. So just fascinating how these different tracks of thought exist. And so but yeah, I just wanted to see if you had any last words for the audience in terms of hormone replacement and estrogen being such an important hormone, and how we can start shifting the narrative around estrogen more so.
Well, I think this, there's two last thoughts. One is, how do you find a provider that knows about it, right? Don't assume that your provider OBGYN knows. So you could try to find a certified menopause practitioner, although they're very traditional. They're not, they do have some information about menopause. They are not going to hesitate to prescribe you. They're not going to monitor your levels. They're not going to look at your estrogen detoxification, but it's better than nothing. I get messages all the time from patients saying, my doctor said, you're fine. And then the doctors told them not to take hormones, or the doctors told them, and you know what, if the doctor is not comfortable prescribing hormones, that is their prerogative. If they feel they don't feel comfortable, you can't make your doctor check your hormones, and you can't make your doctor give you hormones. But what you can do, you can ask your doctor, what is your experience with menopause? How do you feel about hormone therapy? Do you feel comfortable with it? And if the doctor says no, don't take that, or just a genuine, I don't really know, then ask for a referral or go and do your homework. I mean, now with the internet and social media, you can vet your providers. You can look for somebody who's functional trained, either through IFM or A4M. You could look on their social media, their website, whatever, and see and ask. Now you can do those things. We used to only go geographically to the doctor, the local doctor. Now, things are there. So it's really important to know what kind of provider to work with. And I think that, hormone there are some people who don't do well in hormone therapy. I think that number is a lot less than that has been advertised. But I think every woman deserves to hear what the risks and benefits are, have a complete review of symptoms to see what symptoms they are having, and potentially have their own hormones checked to see what their hormone levels are. But traditionally, the North American Menopause Society and the Endocrine Society, the recommendation is not to check hormones, not to monitor hormones. But if you look at the Endocrine Society recommendations for males, check hormones, baselines, give testosterone, monitor. What is the recommendation for transgender hormone therapy? Check hormones, give hormones, monitor. What's the recommendation for women? Don't check hormones, give hormones, don't monitor. It makes no sense.
No sense,
So those are the two things that I think people are really struggling with, is finding a provider, a knowledgeable provider, and also finding, somebody who's going to work with them and check hormones.
Yeah, absolutely. Well, I appreciate that. And thank you so much for your time. It's been a fantastic discussion. And thank you for being on this mission. It certainly gives people like me hope that I can look up to physicians like yourself who are doing this really important work. So thank you again.
Thank you.